Hello, everyone, and welcome to my webinar on preservation deep plane facelift. I'm Dr. Minas Constantinides, and I look forward to spending the next, I don't know, 30 to 45 minutes. We'll go for as long as people want to ask questions. The presentation itself will be about 20 to 30 minutes long. And what we're talking about is preservation deep plane facelift. So this technique that we're going to be talking about really provides a transformative change for people's lives. And this kind of change is, I think, achievable in many different facial types and many different skin types. And so, and so we'll talk a little bit about that, and we'll go into quite a bit of detail as to how we get there and how this process has evolved in my own practice. Now, before we really start talking about this too much more, I just wanted to point out that you all are muted and you aren't able to be unmuted in this presentation. So if you have questions as I'm speaking, if you'd like to write them down in the Q&A box on the webinar screen. So somewhere either at the top or the bottom of your screen, there's a little Q&A box. If you want to put your questions in there, we'll be able to answer. I'll do my best to answer as many as possible after the presentation's finished. If we get through if we run out of time, I'm going to end this presentation no later than 1, including all the Q&A. If we run out of time, there'll be opportunity to reach out to ask additional questions, either through our consultant or through myself personally. So, transformative change, how do we get there? So first of all, a little bit about me. Those of you who haven't looked me up, I've been in practice for 30 years, 20 years in New York as the founding director of Facial Plastic and Reconstructive Surgery Division in the Department of Otolaryngology. That's the Ear, Nose, and Throat Department at NYU Langone Medical Center. And that was until 2015. And then in 2015, I moved my family to Austin, mostly because we were looking for a way to get out of New York and spend some time for the remaining of my practice years, someplace that's kind of nicer to live and better weather and easier to practice. And my wife went to Texas as an undergrad in nursing, and then my oldest son came to Texas and graduated with a finance degree from McCombs. And so while he was here, I got to know Austin a bit and found Westlake Dermatology, and it's been a great fit for us. So my practice is in the North Lamar. It's called Lamar Central, the Lamar Central location of Westlake Dermatology, and that's where we operate. That's where I see patients. That's the only place I am. So if you'd like to come and talk to me and visit, that's the Lamar Central location. I'm double board certified in facial plastic surgery and otolaryngology, and that becomes important when we talk about anatomy of the face. I've had a lot of experience in dissecting faces, both through my training and over my 30 years in practice. And some of the anatomic features of deep plane facelifting are things that I've been working with really for most of my career. I've also been involved nationally in the American Academy of Facial Plastic Surgery as a board member. I'm a senior advisor for the American Board of Facial Plastic Surgery, helping to examine and test candidates who want to become facial plastic surgeons. And I was the founding president of the South Texas Society for Facial Plastic Surgeons when we arrived here in Austin. So a lot of experience in facial plastic surgery. I hope you'll see that as we talk. So what happens to our faces as we age? Well, there are changes to the skin quality changes. There are changes to the structure of the face and brows. Um, there is upper eyelid skin excess becomes important. Sorry. And of course, the area around the lower eyelids becomes baggy and prominent. And just trying to see here if we can. And then we have changes in facial fat and distribution of facial fat. With facial fat changes comes laxity in the SMAS and the platysma. And we'll talk a little bit more about the anatomy of what all that means in just a second. So the important elements of the anatomy, skin we talked about, and then the subcutaneous layer is the layer that holds the fat in the face. And just deep to the subcutaneous layer is this muscular layer, which is the SMAS layer. SMAS stands for subcutaneous musculoaponeurotic system. And the SMAS is what, when we pull on our faces and we lift an area, and we like how it looks when we lift up along the jawline, well, we're moving the SMAS. But what's important is that there are these ligaments between the SMAS and the deep layers of the face called facial retaining ligaments. And if we don't have adequate release of these retaining ligaments, then the SMAS doesn't move, or it can be stretched and give a temporary improvement, but without dividing through the retaining ligaments and moving the tissues above it, then we don't get a long-lasting movement of the face. So when you hear about different facelift techniques, there's the SMAS lift. And the SMAS lift is essentially a lift where the skin and soft tissue and fat is lifted off the SMAS, and then the SMAS is either just pulled, tugged on, or a short amount of the SMAS layer is elevated, and then that is tugged on. But there's no broad division of the retaining ligaments that's required for durable, long-lasting motion. Deep plane lifts are deep to the SMAS. So by raising the SMAS up, but not dividing these layers, so we're raising skin and fat and SMAS all as one layer, and when we do that, we can divide through the retaining ligaments and then move the face and in the neck, the platysma. The platysma is the same thing. In the neck, this muscular layer is the platysma, and again, there are retaining ligaments that we have to divide to get it to move. So these anatomic changes are really, really important to giving a long-lasting and natural-looking lift. Most lifts, like I just said, pull on the SMAS and the platysma to try to create a tighter look. But the pulling doesn't last. There's no release. And so without that release and moving, you can get a pulled look as the lift ages. By longevity, these lifts, typically we start to see problems with durability or longevity of the lift after about 5 years, 7 years at best. Deep plane lifts, like we're about to spend a lot of time talking about, don't pull on these tissues. They release the retaining ligaments and move them. And by doing that, we can reposition that whole layer to where it was about 15 years ago. And this creates a really smooth look that doesn't look pulled, because we're just moving the tissues to where they were. So this unpulled look is that, but the tissues moving to a new position where they used to be and have fallen from is the key to deep plane facelifting. Now, we've heard about You've heard the expression of, standing on the shoulders of giants, maybe, when we talk about the history of what we do. But we're really in a unique place these days because the people that are shaping our concepts of facelifting are are with us and operating today. And on the screen left, you see Mike Nyack and I, and the screen right, Ben Tilley and I. And Mike and Ben are good friends of mine, but more importantly, I've spent time in the operating room with them to see how they do these things. Because I've been doing deep plane facelifting literally since it was first introduced into into the surgical community, 25 years ago. I've been in practice 30 years, been doing deep plane facelifting a long time. But Mike and Ben have finessed this surgery and have created nuances to the way it's done that I think are critical to getting the best possible results that we can get with people still looking natural and like themselves. So good friends, but more importantly, teachers of mine that I've learned a lot from. So here's our first before and after. We saw her before, deep plane facelift, endoscopic brow lift to change the heaviness around the eyelids, upper and lower blepharoplasty to improve smoothing to the transitions between cheek and eyelids and the heaviness of the upper lid itself, and a periorbital around the eye peel. We always will do a peel when we do eyelid surgery. The peel helps to smoothen any fine lines and helps the skin to contract. Because if we're taking these big bags and moving them back, the skin gets loose, and I don't like removing skin. Very few people have extra skin that needs to be removed. Instead, we like to tighten the skin at the same time. Some surgeons like lasers. I like peels. It's one and done, and patients always get a great result. So deep plane facelift with other things. Fine lines are improved, not gone. We still need Botox to improve the smile lines, but you'll see the mid-face creases, how dramatically improved they are. And that's because of this release. By getting underneath these retaining ligaments, releasing this layer, and then repositioning it, we don't have these areas that are adherent. These lines in the midface, in the cheeks, are from these adherent areas that have to be released in order to get easy redistribution. Oblique views, we see the limits of these lifts. So beautiful improvement of the entire face and neck and jawline as well. The limit of the lift is at the corner of the mouth. So the lift can improve tightness and laxity in that area. And look at how beautiful that contour of the jawline is now. The jawline, as we get older, looks like it's short. It goes from here to here. We get a jowl and we lose volume. With the deep plane lift, we're moving the muscle of the neck, the platysma, up and under the jawline, and improving this mass above the jawline and creating this longer, more elegant jawline that's a sign of youth. The limit is here, though. We can't get upturn of the corner of the mouth without doing something else. In her case, I didn't do anything, but if we want additional improvement, we can use fillers after surgery or fat during surgery. You'll also notice, look at the volume in her upper midface is so much improved from here, where she has this falling forward of her volume, lack of deep volume. This deep volume improvement is not from fat transfer. It's from moving her own tissues up into the cheek area to create definition and volume. So this is another critical thing to understand about deep plane lifts. Often patients will have volume deficits that are in the deep layers below where the lift can help. And in those patients, yes, I use fat transfer to help supplement those volumes. But in a patient like this, where her underlying deep volume is fine, it's the volume that's around the SMAS that's the problem. We can move that volume up and create fill just with her own fat. not her fat from her abdomen or her legs, but fat from her cheeks, moving it up and back. And so another real important um, opportunity that deep plane lifts give us that other kinds of lifts don't. Look at the smile lines are so much improved, and she just looks great. Jaw neckline, much improved from where it was, almost straight here. Now she has, again, a nice cervicomental angle, a nice jaw neckline angle. Incisions are really hard to find. Laxity is much improved. She still has some laxity, yes. We want to leave patients looking natural. A very, very highly chiseled neck in a patient of this age, just to me, doesn't look as natural as someone who just looks better, healthier, more well-rested, and not like someone else. Here's another patient. This is just a deep plane lift. She was fine with her eyes and brows and everything else, but wanted her jawline and neck improved. So we see some jowling in front view that's improved. We see some heaviness in her nasolabial folds, pre-op that is improved post-op. Volume in the upper face is better. Jaw neckline, this long, elegant jawline now, where we started off with a short-looking jawline, now long and elegant, just like it should be as we get older. We lose a lot of this because of laxity and time, and we can redistribute everything by releasing. Again, the key is the release and moving backwards. Now, this is not a preservation lift. We'll talk about preservation lifts in a few minutes, but this is sort of an older style, meaning older than 2 years old in my practice. I started doing preservation lifting when it was first described about 2 years ago, and have been really, really happy with the outcome with preservation lifting. Looking down, all that laxity is much improved. Still looks like herself, just better. Here's a patient who has lost a lot of weight. And so with weight loss, we have loss of fat in the layer between the skin and the SMAS, but we also have deep volume fat loss. And so in her case, she had a lot of deep volume fat loss, but also a lot of superficial fat loss. So deep plane facelifting can help to smoothen, can release and move her own fat up to where it needs to be to help give her a better distribution of the volume that she has there. Having said that, we didn't supplement her volume loss with any outside fat, any additional fat. This is all her own fat just moving. It's a good example of what the limits of deep plane lifting can do. All the smile lines, though, much improved with deep plane lifting, just by releasing again all those retaining ligaments and moving things back. Beautiful long jawline reestablished, moving her volume from where it had fallen up into her midface so it looks more natural. Could she have used some fat transfer to help augment this even further? Yes, but we didn't do that. We just did a volume transfer. We just did her deep plane facelift to move that volume around. The longevity in the neck, improvement in all the laxity. Looks like herself, just like much improved. And another example of mid-face lines and how much they can smooth and improve with that release. Improved jawline. Smile lines much improved. So let's talk about what preservation deep plane lifting means. So what is the difference? Here's a little table that talks about the differences, and then I'll show you some pictures. But with a deep plane lift, we have to raise skin about 1.5 inches to 2 inches in front of the ear. Preservation lifting lessens how much skin we raise so that there's more, so without having to raise skin alone, we improve blood flow to the incision lines and to the back area of the face and neck area. So with deep plane lift, typically skin elevation was all the way across the neck. Now with the preservation lift, we have a limited skin elevation in the neck, again, improving blood flow to the skin and lessening healing problems. Suction drains, I use suction drains still, but with preservation lifting, we get to take them out a little bit earlier. We'll talk about why that's important in a minute. And but the extended deep plane release that's so important is preserved in both techniques. There's no doing less surgery in the deep plane with preservation lifts. It's just less skin elevation. So in this woman that we saw before, if I did a standard lift on her, and this was my skin elevation. The skin is elevated, incision lines are in the hairline, come to the top of the ear, in front of the ear, behind the tragus, around the earlobe, and to the back. With the preservation lift, the skin elevation is shorter in the face and in the neck, and we still have to raise, in most patients, in the front of the neck, the skin off the middle of the muscle so I can work underneath this area. But with a preservation lift, there's a bridge of skin that's left intact. This bridge can vary depending on how much work has to be done in the neck. So preservation lift is less skin elevated. Here's a picture from an article co-authored by my friend Dr. Talay that we talked about earlier. And this is a good illustration of what is lifted in terms of skin elevation. Skin elevation is in the green with a standard deep plane lift, but with a preservation lift, the skin elevation in the green here and here is much less. And the red just shows the deep plane elevation and the movement. So after a regular deep plane lift, because of the longer skin elevation, there is still a fair amount of skin only that's been raised here and here. With the preservation lift, there is almost no skin only that's left in the face, and in the neck, it's this area back here, behind the ear, and the central neck only. So much less skin elevation means a smaller dead space, smaller area that fluid can collect in. There's still some areas that fluid can collect. That's why I use drains still. But because there is much less of a space, the drains can be removed earlier on. The reason I use drains is that these areas of dead space can collect fluid or serous fluid, mostly called seromas. If we get seromas after a facelift, the healing process is much slower. We have to drain them. They always cause irregularity of the skin of the face and neck where they occur. And so we really, I use drains primarily so I don't get seromas. Before I was using, for a long time, I was putting no drain in a patient or just overnight. And I would get, my seroma rate was about 10%, which is really, really frustrating for patients to have to 1 in 9 patients having to have a longer healing process. Now you have to have a drain for a few days, but there's the upside is huge. Healing is very predictable and beautiful without having complications of healing like with seromas. Let's talk about the central neck for a second. In some patients, especially younger patients that have laxity here, but there are no jowls yet, if there's no significant SMAS descent or SMAS loss and no jowling, then we can do something called a deep anterior neck lift, which is really the same as a deep plane. It's the same neck work in the central neck as a deep plane lift, but we don't have to do the rest of it. If it's just laxity in the central neck in a younger patient, typically under 50, we can just do a deep anterior neck lift. The key is there jowl formation? If there's jowl formation, then that means the SMAS has weakened. And remember, it's one layer. Platysma and SMAS is one layer. So we have to kind of lift that whole layer to get adequate improvement and longevity of the result. But in someone who has just laxity here, then we can often do a deep anterior neck lift. More information about that if you're interested from Devin when you come in, Devin and with me. So here's another example, deep anterior neck lift, deep plane facelift, quad bluff, and a header peel, deep peel around the eyes to try to get even more smoothing of the skin around the eyes. Um, a much improved jawline, longer, more elegant, a improved volume in the upper mid face, and a real natural look for her. I did not do her lips, so don't look at that. um, Again, natural looking, nothing that looks abnormal or overly done, just improvement of all the laxity. Incision lines, really hard to find in all these patients because we're not pulling on the skin at all with this operation. We're moving the tissues back and then just trimming off what's extra. There's no there's no skin excision during the surgery. I thought you might be fun to see someone as they're healing. This is 1 week after a deep plane facelift and a perioral header peel. And so 1 week after preservation deep plane facelift in this case, and a perioral or around the mouth deep peel to try to get smoothing of that skin around the mouth. And here she is at 3 months, obviously much improved. And she was not interested in treating her eyes at this time, and so we didn't. I really follow what my patients want in terms of what areas that they're bothered by. In her case, she was really bothered by this in her neck. Look at all that crepiness in her neck that is much improved now, but her eyes just didn't bother her. And so, we have a discussion about, what there is to do about that, and decided to just treat the face and neck with a preservation deep plane lift. Header peel, these are spot peels, which are red initially from the header, that deep peel for those brown spots. And she heals beautifully with that. Really can't tell there was anything done at 3 months. I'll say one thing about fullness in the area underneath the chin. This fullness lasts for about a year. It's very interesting that when we see patients back between 3 and 12 months, there's significant improvement of this swelling or fullness that's deep to the muscle. That deep swelling takes a while to go away. But look at where we started and look at where we're ending. And of course, all the smile lines improved, and that improvement is a durable, lasting improvement. Other side, same idea. I'll just talk about this area for a second. So Botox would help this area. However, what really would help this area is a brow lift, and she just wasn't interested at the time. And looks great and feels great, and that's the key to happy patients. Let's talk about fat transfer. So fat and nanofat. This is an older patient who had had a previous facelift a while ago, and she just wasn't up for another facelift, but wanted to treat some volume problems. So these are my markings on the day of the surgery of just fat transfer, what we can do. Temples had significant volume issues. This crease above the eyelid, which gives this hollow, more skeletal look as we get older, can be filled with fat. Fat in volume problems in her upper cheeks can be improved, around the mouth area, and in the cheeks themselves, the lateral cheek. Nanofat is fat without fat cells in it. So we take fat and we process it further to just have left the stuff and fat that makes the skin look great. So nanofat's great for areas of thin skin, like around the eyes, around the eyes, and nanofat's great for lips. If you don't want to she definitely didn't want full lips. She just wanted smoother lips. And so we see after 1 month after fat, nanofat transfer, just a softer look. And this is her fat taken from her inner thighs, processed, nanofat in the upper lids, fat in the temples, fat in the upper cheeks, nanofat in the eyelid, nanofat in the lips, nanofat in the fine lines around the mouth, and fat in the jowly areas to try to give improvement. I think, significantly improved with a 2-hour procedure that requires just fat transfer. We often will combine this procedure with facelifting, But I just thought it'd be fun to show you what fat can do in patients with just without lifting, just fat. Beautiful, soft, subtle changes. So, common questions. How long does a preservation facelift take? It takes 6 hours. In my practice, it takes 6 hours. We do it with IV sedation by me, so we don't have to intubate you unless there's some medical issue that like sleep apnea that we'd be worried about. Um, that also means no additional anesthesia fees, which makes it a little bit nicer in terms of cost. Recovery's faster without general anesthesia, and I think we have less bleeding and bruising because of that. You'll be sleeping. You won't be aware of anything. You won't have any unpleasant memories, but it's not a general anesthetic. It's just a deep sedation like a colonoscopy that lasts for 6 hours. The limit for me is 8 hours of IV sedation. So if we were doing, say, brow lift and upper and lower lifts and a deep plane preservation, deep plane face and neck lift, well, that would have to be a general anesthetic because it's a 12-hour surgery. But do you really want a 12-hour surgery? So very often we'll have a discussion about, I can do a 12-hour surgery, but it's a general anesthetic, the recovery is going to be long, or do you want to stage the surgery? So you pick what you hate the most, pick your face and neck lift, or you pick your brows and eyes, and then we can stage it. We do one, then once you've recovered adequately, 3 or 4 months later, we can do the second. Well, I'm scared I'll feel pain. Everyone worries about pain. This is really not a painful procedure. During the surgery, you won't feel anything. When you come out of surgery, you won't have any memory of pain. Post-op pain, we treat typically with Celebrex. We give a narcotic prescription if patients need it, but we tend to treat it with non-narcotic means, and it really, about half my patients don't need a narcotic at all, and the other half just for the first 48 hours when pain peaks, a narcotic might be helpful. How can I heal faster? We talk a lot and give you a lot of information about how to heal faster, including dietary recommendations, products, and lymphatic massage, among other things, post-op. And how long do the results last? They really do last 15 years. I've been in practice 30 years doing deep plane facelifting of one form or another for most of that time, and I really have not had to repeat a full deep plane facelift in my patients. Occasionally, a patient will have some laxity in certain areas that we'll want to do a little touch-up procedure on, but 90% of patients don't need anything, 95% of patients don't need anything and do well and don't need another surgery. If you do the surgery when you're 50, you continue to age. By 65, you'll have reached the point in your tissue where it was at 50, but you're looking so much better than you would at 65 that most patients don't feel like they need another surgery. Do I use drains? Yes, we talked about drains. I use 2 drains, one on each side, to ensure no seroma formation, which is a faster recovery. I also think that drains help to pull out swelling faster, so I think healing is better and faster. They stay in 2 or 3 days. In areas that aren't drained, I'll use a hemostatic net, which are stitches that get removed at 3 or 4 days when the drains come out, or 2 or 3 days. They help to bring the tissue together that has a space underneath it that isn't being drained. So typically that's in front of the ear for me. So after surgery, we wrap overnight. At day 1, we take the big wrap off. We see the next day, take the big wrap off, put a smaller wrap. Drains come out day 2 to 4, depending on how much is how they're putting out. Sutures are out at day 7. Lymphatic massage can begin then. 2 to 3 weeks, patients can start to get more active. They compress only at night. They may return to work. And the contraction phase of healing begins. This is the phase where things heal in. Before 2 weeks is in the inflammatory phase of healing, where things are still building up to heal. But contraction goes from 2 to 3 weeks for 3 to 4 months. And that's when things heal in. It's also when things can get lumpy bumpy in the neck, in the face. If things are getting lumpy bumpy, we talk about massaging with a beauty bar, which we talk about. It's a vibrating little device that can help with the healing. 3 to 4 weeks, patients are well on their way to recovery, can go out with friends, not feeling like that anyone's going to notice anything, and increased activity is going. Most patients are doing a full workout by 3 to 4 weeks, and then 2 months for anything important, vacations, public speaking, pictures. 6 months. Two to 3 months really before you're going to be in a wedding picture with your granddaughter, and then by 6 months, the numbness and firmness are really only in small areas. So, what's next is that you'll get a follow-up email from the practice. Um, Ms. Devin Wright is my cosmetic consultant, and she will contact you by email. Um, if you can schedule a complimentary consultation with Devin, please take a screenshot of this picture if you'd like. You can reach her you can also email her, but again, you'll be getting an email from her since you've registered today. devinw@westlakedermatology.com. You also may schedule a consultation with me. It's a paid consultation by calling my office or booking online at the Westlake website. And then finally, it's the holiday season. We are a giving group here at Westlake Dermatology. Our holiday gift to you is 10% off our facelift fees um, uh, if you have your surgery by the end of February. And so if you're interested in getting a quote from us, Devin will reach out, respond to her email, or give her a call, and 10% off our surgical fees uh, are our gift to you. Hopefully you'll enjoy that. So at this point, let's stop sharing. Great. So at this point, I know that we have some questions, and I don't know if Karen, are you on, or that you can
Yes,
maybe
I'm
help me
here.
with some of these questions?
Yes, and we have a few. Um, so I'll just jump right in. How do you handle large mandibular, glands, which have been a lifelong issue and combined with aging are the focus of the need for a neck lift?
Yeah. So first of all, depends on your age, but so submandibular glands uh, are are part of the central neck work that I do in patients that need it. And almost everyone, well, if you have a very thin, flat neck that just with just droopy muscle, sometimes we don't have to open the central neck. But if you have fullness here that's deep to the muscle, it's usually fat or additional muscles that we used to use for chewing that we never use anymore. And there's submandibular glands, which are the glands that get larger and or they fall as the ligaments around them age. So submandibular glands I look for and can remove, not entirely. If they're really big, I can't take them all out, but I will always do a partial excision when those glands are too big. So it's an important question. Thank you for asking it. We always look and we remove them when they're a problem. If we don't remove them and you pull the platysma up around them, some surgeons think that by pulling the platysma, creating a sling of muscle and pulling it up, it will pull the gland up with it. It just doesn't. What often will happen is the gland becomes more silhouetted, more highlighted when the muscle is pulled around it. And so you really have to reduce the bulk of the gland. And I learned how to do that from Mike Nyack in St. Louis, and I love the technique, and I think he does a great job.
All right, great. So next question, I think you kind of already addressed a little bit, but what does aftercare look like, especially the first 10 days and interaction with the doctor and office?
So we see you the next day. We see you at 2 or 3 days to take the drains out. Whenever we ask you to log your drain output, and whenever it's below 5 ml, which is a teaspoon per side, in 24 hours, we take them out. It's usually on day 3 or 4 after the surgery. Then we see you again at 7 days to take the stitches out. I'm there for all those visits unless for some reason I have to travel somewhere, but usually I'm here for all those visits. And then and typically by 10 days, most people are really feeling pretty good. They want to increase their activity level. They're feeling up to doing that. Just we have to be cautious not to do too much too early. Remember, we're redistributing muscle. And so ligaments and muscles. So you don't want to tension those, stress those too soon. So with cautiously, you can increase our aerobic activity a bit as long as you're not doing real core exercises at 10 days. But by 3 weeks or so, you can start to test the area, see if it can take it, and then if you're not getting a lot of swelling and pain, then you increase as your body tells you is okay to do. So just pay attention to how you feel, and that's usually the best way to know when you're ready to increase activity.
Dr. C, I'm wondering, on that question, they're asking about how much interaction there is with the doctor in office. Maybe address if you have patients that come in from out of town, how long they need to stay. I'm wondering if that's what the question might have been.
Yeah, I don't know what I mean. We interact on every visit, and there are a lot of them the first few days. But it's really hard to recommend that you, if you're flying, if you're driving, it's a different thing. You don't really need to, depending on how far you're driving, you don't need to stay in town. Um, uh, as long as you can make make those appointments. People that are coming from out of town, really from out of town, have to stay until their drains are out and until their stitches are out, typically. So that's 7 to 8 days. You can fly at 8 days, but usually I recommend you, if you can, stay in town for a couple weeks. That way the swelling is down sufficiently so you're not stressing the area with too much swelling. But patients say I have a fair number of patients that come in from Houston and Dallas, and they'll come back and forth. So you stay overnight. We see you the next day. You might stay an extra night because you're still not feeling up to driving 3 or 4 hours. The next day, stay a couple days, go home, come back for drain removal if you're and then go home and then come back for suture removal if you're within driving distance that way.
Sounds good. How many facelifts have you done, and do you specialize in any specific surgery?
I think we just talked about that for about the last half hour or so. So in terms of how many I've done, uh, I'm gonna say I've probably done 2,000 facelifts, maybe 1,500. More. I'm. It's between 30 and 50 a year, and that's in New York. I was probably doing 20 a year, so 2,400. Probably I'd say somewhere between 1,000 to 1,500 facelifts. I specialize in preservation deep face and neck lifts. So that's what we've been talking about for the last during this presentation.
Right. And then I think this question came in when you were talking about the first patient that had the bleph and the brow lift and everything with it. And she's asking what was the cost of that particular surgery?
Yeah, I'm not gonna go into cost. If you're interested in cost, then you'll please contact Devin and we can figure out. Costs vary depending on what you have, uh, what you need. So, how much, which of these things are we doing for you? Have you had previous surgery? That affects cost. And actually, the other thing that affects costs is if you've had any other non-surgical interventions that are significant. So if you've had a lot of RF tightening for your neck, for example, well, that creates scar, and that costs more for me to be able to get through that, and because it takes longer to do that surgery, and your recovery will be harder. So you just need to be aware. We need to be aware of what is involved in the complexity of your surgery, and we price things accordingly. But Devin can give you a really exact estimate when she reaches out to you.
Okay. Are you able to share the age of the first model, and what is the time elapsed between her before and after photos? Interested in how much recovery time was required. You probably
Sure.
have already addressed that since then, but
Sure. And Karen, are you intending to call me? I'm sorry.
no, just
Okay.
one.
Um, so the age, she was in her mid 50s, and that before and after, most of the before and afters that I showed, except for the ones that were specifically that I specifically mentioned, are at around 6 months. It's rare that patients need to come back for more after that. However, I see many of my facelift patients back for Botox and that sort of thing, so we try to keep up with their pictures if we can.
Okay. Can you explain the term skin elevation, meaning the skin is totally detached from the underlying layers, correct? And is that detached using blunt or sharp instruments?
So I guess um, I guess I would wonder why the questioner was asking that particular question about technique, that specifically.
Maybe
So
wondering more
having,
about.
having, having said that, yes. So the skin is elevated for a short distance in the face, so I can access an area that I can get into the deep plane. In the neck, the skin is elevated uh, to the basically to the edge of this big muscle, the sternocleidomastoid, and then we can access deep underneath the platysma in that deeper plane. So skin elevation means skin and fat are elevated off the underlying tissue. In most cases, it's the SMAS, but back here, there's other tissue that's not SMAS. It's mastoid fascia or premastoid fascia. So, and we always use sharp elevation for those, for skin elevation. You can't elevate skin bluntly, really. It's always going to be a sharper elevation.
Okay. Are you doing neck lift with these facelifts? Do you always do a neck?
All facelifts get a neck lift.
Okay, great. She's
Most
her
neck
neck.
lifts, most neck lifts also get a facelift because we talked about it's one layer. Platysma and SMAS are one layer. They just change names and a little bit of the character. So if I want a sharp jawline, I'm going to elevate the platysma, but also elevate the SMAS, which improves the neckline. So almost everyone gets a face and neck lift if you have jowling. If there's only central neck problems with no jowling, then we can do a limited central deep compartment neck lift. It's called a deep anterior neck lift. But but most patients will get a face and neck lift to get everything improved.
And then we have a question of, will you be showing any examples of men who have had procedures, which I don't think you have any included in here, but
No, I
uh,
didn't include any, and there are a few on the website. Deep, I'll just mention that the preservation deep plane face and neck lift is a wonderful operation in men because the tissue is heavy. Also, in women who have heavy tissues, it's an amazing surgery because the power of the ability to move that tissue by releasing and moving it is much better than using other techniques. So I love it for men. looks supernatural. There are some examples of men on our website, um, and I hope you visit those.
Okay, how does weight loss and weight gain impact these results over time, especially with women who may be undergoing perimenopause and vast hormonal changes?
Yeah, so we like patients. First of all, I don't do facelifts and BMIs over 32. So if you're very heavy, your BMI is over 32, we don't we don't do facelifting. Um, there's a sweet spot. It's still okay to have a facelift, say if your BMI is 30, but if you're expecting to be able to lose more weight, say using one of the GLP-1 agonists, I would encourage you to get closer to your weight loss goal before surgery, because the tissue is less heavy if it's thinner. And so the less heavy the tissue is, the better mobilization I can get and the better outcome you'll have. However, remember we're removing fat compartments with a deep plane release. So the fat that you have will move into a new position where it was when you were younger. And then any weight loss or weight gain is natural looking because we're not disrupting these normal fat distribution. So perimenopausal weight loss and weight gain are real important problems. Um, but this technique gives patients a wonderful result regardless of where they are, as long as they're not too heavy.
All right. How much of a fat transfer is absorbed and doesn't stay?
Yeah, so the the answer is somewhere between 60 and 80%. I think in my practice, it's hard, right? We're not doing volume studies with ultrasound to try to assess that. But what I'll say is that most patients after a fat transfer, I think it's about a 70 to 80% take, meaning the fat that we put into its new place acquires a new blood supply and can live there like it's always been there. 60, I think it's 70 to 80% is that take. We know at 6 months what kind of result we have. Very rarely, less than 10%, we have to go back and do more fat transfer, but most patients get a really adequate improvement without need for additional fat.
Okay. Is this procedure, the 6-hour version, done on an outpatient basis or overnight hospitalization required?
Everything we do is outpatient. So 6 hours. Remember, it's IV sedation, anesthesia. Recovery is very fast. Most patients we finish and they're able to get dressed and go home within an hour or so. Now, you shouldn't be going on Amazon and buying stuff that day because you won't remember what you did that you did that the next day. But then nonetheless, recovery is fast and you're able to safely go home. Um, Most patients just have their partner or a friend stay with them that night. We encourage you to have someone that stays with you overnight. Um, and we have nursing services available for those patients that need someone to stay with them because they don't want to burden one of their friends or they just don't have anyone.
Okay. Is there a lot of post-surgery bruising?
I think you saw my 1 day patient. That's she had hardly any bruising. Bruising is variable. We do a lot of we do I think we do a lot in the operating room to ensure that there's less bruising. One of the things that I like is administering intravenous tranexamic acid, which is something that interferes with the ability of a blood clot to dissolve. So microclots that always form when we raise tissue, there's more stability to those so that there's less bruising. And I think drains help with bruising. So bruising is never really an issue. Any significant bruising that there is gone within 10 days in most, if not all, patients.
All right. During recovery, oops, Devin has jumped on and she's answering some of the questions and they're kind of moving around. Sorry. But the question had to do with sleeping elevation. Are there any special requirements regarding sleeping upright for several
Yeah, I
days out?
mean, people do what they're comfortable doing. It's nice to have your head higher than your heart, and so that helps the swelling. Sleeping in a recliner, sleeping, with a some sort of incliner for your bed, sleeping up in a chair. I mean, all those things, I don't think they're that important. Um, but uh, but many patients do them because they feel like they'd like to maximize or minimize the amount of swelling they have. Honestly, I think the compression we use is very helpful. The drains are really helpful, and patients, if they sleep on a few pillows, is usually adequate.
Okay. Have you performed this type of facelift on Black females? Or
Yes, but not many.
yeah, okay.
Um, I do have a few black women in my practice with this surgery. Because we're not pulling on the skin, there's very little. So the pull is deep. Extra skin is just trimmed off. Very little hyperpigmentation or no thickening of the scars, no keloid issues, very, very little issue with any of that. And because the skin elevation is minimized, uh, darkening of the skin is rarely seen. So this surgery works well in patients of color.
And what is the average age of your patient for facelift?
So most patients have the surgery mid 50s to early 70s. I think that's probably, you know, the middle of the bell curve. Uh, I've done the surgery as young as 38, and I've done this surgery as old as 85. It just depends on the sort of what the patient needs. And I don't go by chronologic age as much as what's going on with the anatomy, and can this operation help?
It looks like we have about 3 minutes, so I'm going to keep going, but we probably aren't going to be able to get to all the questions. I just wanted to mention that Devin is typing in some answers too, and then she can try to follow up with everybody who we don't get an answer to.
Absolutely. I mean, we're really eager to hear your questions. So just respond to the email you get if you have any questions, and we'll definitely answer them for you.
Okay. What are the options for the forehead? I go in for Botox, but are there any long-term options?
There, that there, there, there are definitely options for the forehead. What I'm gonna maybe suggest is that you wait until my next webinar on brow lifting and blepharoplasty, where we'll discuss that in more detail. But it's a little bit too long an answer to be able to adequately answer right now in just a minute.
Okay. Are there any medications we need to stop taking prior to the procedure related to bleeding risk?
Yeah, we go through all that during your preoperative visit. Aspirin, we like you off aspirin and nonsteroidals like ibuprofen for a week. There's some fish oil, for example, is a potential blood thinner. We like you to stop just a few days before. Any of the homeopathic, there's some homeopathic melatonin is a homeopathic medication for sleep that you'll want to stop because it can cause bleeding. There are a bunch that would go through at your visit before you decide on surgery.
Okay. One more question. When you open up the face, do you sometimes make game time decisions to use SMAS only in some parts? Meaning, do
Never,
you use
never,
both deep
never,
and SMAS?
never, never. I will not do a SMAS only lift anywhere. It doesn't work. There's no release. There's no movement. It doesn't last long. Looks weird. Don't like it.
All right. There were quite a few questions we didn't get to. If they weren't asked anonymously, I'm pretty sure Devin can help address all of those. If they were asked anonymously, then just feel free to email Devin after the session.
Great. And I see one that came up. When's the next webinar and how can you sign up for Brow Lift Bluff? That probably won't be until January. I'm going to give myself a break in December and just focus on surgery. We're doing we're booking almost completely already. So January, middle of January-ish. But look for an email from our practice in January for that, and also on our specials page on the website. Thank you very much, everyone.